Perfect. Okay, so welcome everyone. Hi, I'm Courtney. I'm with PRMA. We are excited you're here tonight. Tonight is about you guys and having questions answered. We've got a great panel of specialists up here. They are going to briefly explain what they do in the breast cancer journey for you guys, and then we're going to open it up to questions here with you guys, and then we're also streaming online. So we've got a ton of viewers that are going to be tuning in online and asking questions, and I'll be reading those off. So this is just casual conversation, learning. That's what we want to do tonight. So thanks for coming, and yay. All right, Dr. Boatsman, you want to kick us off?
Sure. Hello, my name is Justin Boatsman. I'd like to thank the people who came here today, as well as the people who are listening and watching, and thank PRMA who helped set this up. I'm a diagnostic radiologist, and so what we do mainly is imaging. So a lot of times we start the journey with a screening mammogram or screening imaging, and then we continue on if any diagnostic or subsequent imaging is needed, and if from there any intervention or biopsy is needed, we are involved there. We perform the biopsies often, and if any additional imaging is needed, MRI, etc., we are involved in that process and any other support that the rest of the team needs provided as long as it's in our specialty. So that's where we are in the journey, and I'll pass it on to my colleague here.
Hi everyone, I'm Rachel Larson. I'm a physical therapist and a certified lymphedema therapist. So I want to thank Prima and Courtney for inviting me here today, because I will tell you, when I first started my clinic back in 2002, nobody knew what the role of physical therapy was in breast cancer treatment. And we've come a long way since then, and to be considered a part of this important panel is a real honor for me. Just to let you know, physical therapy will come in at any point during the stage of a person's treatment or recovery after going through breast cancer. So you might encounter a physical therapist as a result of having shoulder problems, shoulder pain, loss of motion, neck problems, lymphedema, cording, tendinitis, bursitis. You know, all sorts of things can happen to a person as they go through treatment, and I can intervene at any point in that treatment, from immediately post-surgery to years after, you know, for things like lymphedema that may occur many years down the road.
Hi, my name is Brittany Debary, and I am a general surgeon. I have a special interest in taking care of women with both benign and malignant diseases of the breast. So I'm oftentimes the first doctor that you see after you've been given the diagnosis of breast cancer. As a general surgeon, that's sort of our role, and so we discuss treatment options, mostly related to surgery. So we discuss partial mastectomy, mastectomy, and then the beginning discussions of the reconstructive options as well. And so I'm sort of that part of the journey, and I'll often refer patients to the other specialists on the panel to help in that discussion and decision-making process to figure out how best to treat you.
Are we introducing ourselves?
Yes.
I thought so. I'm Steve Pisano from PRMA. We are a practice here in San Antonio that's dedicated to breast reconstruction. We perform all types of breast reconstruction. I would say some of us in the group have a special interest in tissue transplant breast reconstruction, but we're a full service organization, and we try to provide what's best for a specific patient. In this day and age, in the world of breast reconstruction, it's shared patient decision-making, or hashtag shared patient decision-making, and so we try to work carefully with patients to give them a reconstruction that fits their needs and the problems that they have that need solving. I would echo what Dr. DeBerry said. I work with all the people on the panel, and we're kind of going out of order in the sense that our practice, and for me specifically, we're at the end of a very wide funnel, and we're oftentimes maybe the last person the patient sees in the process. So our patients come from a variety of sources. Certainly everybody who's seated here would be intimately involved in what we do, but we're kind of in a close relationship with everybody here in the community and depend upon those referrals. And we love that about our community.
I'm Amy Liang. I'm a medical oncologist, and the role of a medical oncologist in the journey of breast cancer treatment is a little bit more of a global approach than the surgeons take, although most breast surgeons are very cognizant of the entire health of the patient and total body wellness, but it's really our job to be thinking about not only the cure of the cancer locally in the breast, but also the cure of the cancer in the rest of the body. So what we do when we sit with a brand new patient recently diagnosed with breast cancer is we look at risk factors. And so we look at things like the stage of the cancer, the biology of the cancer, risk factors for recurrence from a genetic standpoint, a hereditary standpoint, and from genetic factors having to do with the cancer itself. We have a lot of different tools that we use to assess what a cancer's risk is that it could come back someplace else in the body years down the line, and that helps us make recommendations for treatment, particularly medication treatment, radiation therapy treatment. And we also stay with the patient for many, many years beyond the initial treatment of the cancer to help monitor for recurrence, give reassurance, manage symptoms that come from the treatments we give, and much more.
Hi, my name is Renee Littleton. I am a certified mastectomy fitter, as well as a certified lymphedema therapist and a licensed massage therapist specializing in oncology. My role in cancer care right now is to assist women who have either had mastectomies and decided not to have reconstruction, get fitted with the prosthesis so that they look whole, feel whole, and beautiful. We also take care of those that have had reconstruction, maybe in between surgeries, that they want to look complete in between that time, as well as supply compression garments. We do have the option of helping folks that have been diagnosed with lymphedema. And we're a big part of the educational aspect of patients before and after surgery. That way, you're not surprised, with this is a possibility after you've had surgery or any procedure. So we always welcome the fact that we are an avenue for you to come to if you have questions in regards to the steps that you have to take to look whole and complete. We have a boutique. It's called the Pink Boutique, and we don't just see women, we see men as well. So it's one of those things where all of us are connected, and we have great relationships with the physicians. That way, everyone's kept with the up and up. And having the background that we have, we might actually see a patient who hasn't been diagnosed, but we can get in contact with the physician to let them know this is what we're seeing, and we'll send them back to the doctor. So we've got this good niche, and I'm happy to be here.
Hello, my name is Stacy Schuler. I'm a breast health nurse navigator at Methodist Hospital, and I specialize in breast cancer. And as part of our role, ideally, I'm put in contact with the patient when they're first diagnosed, because that's typically when they're most vulnerable, they're high anxiety, a lot of questions, a lot of concerns, a lot of uncertainties. So it's a physician-led, or physician-referred, service, or a self-referred service. So hopefully, again, we get put in touch with them immediately. Our role is to support the patient throughout their continuum of care. So as you can see, they sometimes see many different people during their journey, and we're that one consistent person that's with
Okay, so this is our specialist panel. So feel free, if you've got a question, we're just, pretty casual here, so just stand up, feel free to ask, and then online as well. And we actually do have an online question, so I was going to go ahead and kick us off on that. Dr. Liang, what are yours, or I guess any of you guys really, but what are the screening recommendations post breast cancer surgery? Yeah, I was going to say.
Well, screening recommendations is kind of a big topic, but specifically after treatment and completion of treatment, certainly want to keep somebody on a regular regimen. If you've been diagnosed with breast cancer, annual screening I think is recommended. You should be plugged into a pretty good team, so if you need any enhanced screening beyond just the mammogram or mammogram and 3D mammogram, then that could be based on various factors that are unique to you as an individual. In the immediate post-treatment plan, there can be some factors as well. People may have a little more intensive screening for the first year or two every 6 months, but once you complete that immediate post-treatment period of 2 years, then certainly if you've been diagnosed, I would do it annually and make sure you know all the factors that are unique to you, breast density, if you had any other aggressive or suspicious features in your cancer that would make you go to enhanced screening, which may be adjunctive ultrasound to your mammogram, or in the highest risk people, even breast MRI with the mammogram as well.
Yes, ma'am.
Can I expand on that question that was asked online? How about when you've had flap? And maybe it's Pisano, Dr. Pisano can help us with that. I've run into some problems there. My doctors are recommending no screening, and for me, that makes me very uncomfortable. So that's kind of my question, is the flap.
Starting off with it, this is a very challenging topic. So for me, post-mastectomy and flap reconstruction, or implant for that matter, screening, the short answer for me is no. However, the long answer is you're going to do self-examinations, because in my experience, a recurrence of cancer, and that's, I'm cutting to the chase, that's what we're worried about. What you want to know is, what can I do to make a diagnosis for a recurrence of cancer? Or in the instance of a woman who's had a prophylactic or preventative mastectomy, say they have a genetic syndrome, maybe their first occurrence of cancer. Okay, so self-examination, because in my experience, usually a recurrence is going to present as a small mass between the flap or the implant and the native breast skin that's left. Okay, so you don't need an imaging study to do that. One more time, however, it's not always so simple as that. So there may be instances where you would recommend a patient to have imaging if, for example, their original diagnosis, now we're getting into some technical talk, and I'll definitely defer to my oncologic and surgical oncologic colleagues here in a second, but let's say the original diagnosis was DCIS and it was diffuse or multifocal and high grade at that, okay? And we know, maybe I'm working with Dr. DeBerry, and we know that that tumor or that process was very close to the skin, okay? That might be an instance where we say to the patient, you know, in your specific circumstance, as Justin said, I'm going to call you Justin because I have a son named Justin, you may want to do surveillance, and we may want to put the patient on a schedule depending on what we know their pathology to be. So I hope I haven't confused. Ordinarily, I'm asked this all the time in the clinic. So my short answer is no. The long answer is it could be yes, depending on some of these circumstances, but I certainly defer to my colleagues. Yeah.
Okay. So I think think that to answer the question regarding screening after surgery, it's very important to discuss what type of surgery you've had, right? And so patients who undergo a partial mastectomy or a lumpectomy, we have a very specific regimen that we use for those patients because they still have a significant amount of breast tissue remaining. Patients who have undergone mastectomy and have had reconstruction, as everyone has said, there's a lot of controversy, there's a lot of debate about what is best. And I think that we kind of try to tailor that to the patient when we have that discussion. And so to say, no, you don't get any imaging at all, I think is probably not right. Again, we talk about shared decision making and just having that discussion with patients and being open about what the options are. So it's certainly an option to have a mammogram after you've had either tissue-based reconstruction with an autologous flap or you've had implant-based reconstruction. You can still have a mammogram at that time. There is some discussion in the literature that having a baseline mammogram after reconstruction somewhere between 1 and 2 years after the reconstruction is what is currently recommended. Now again, there's a lot of debate and you could put 10 people up here and you could get 10 different answers. And so it's really, again, about sort of discussion with the patient, and it's looking at your risk factors, as Dr. Pisano said. What are your risk factors for recurrence? How aggressive was the tumor before? Where was the tumor located before? And so those are all things that we consider when we're making those decisions.
Briefly, just someone online just would like to just ask, if there's a high or low chance of recurrence of cancer after someone's had a double mastectomy. Just briefly, just touch on that.
Dr. Liang is going to take that.
The answer really is it depends. So a lot of different ways to answer this question. Generally speaking, following a mastectomy, with or without reconstruction, the risk of recurrence in the chest area is 1 to 2%. 1 to 2%, generally speaking. There are situations where that number may be higher, as Dr. Pisano said, if margins were positive, if the tumor had been very large to begin with, if the lymph nodes were involved, especially large numbers of lymph nodes had been positive, the risk of recurrence in the chest area is higher than that. The other nuance to the question is, because it was phrased double mastectomy, many women have the idea that if they have breast cancer in their left breast and they remove both of their breasts, they're going to improve their cure rate and reduce their recurrence rate by removing their opposite breast. And generally speaking, that's not true. If a woman has an inherited mutation, like a BRCA mutation, then yes, the opposite breast is at significant risk for developing not a recurrence of the first cancer, but a second primary cancer, a brand new cancer in the other breast. And so sometimes preventatively or prophylactically removing the other breast does improve their risk of having cancer not come back. It does not improve their survival rate. So women don't live longer because they remove their opposite breast, even in BRCA mutations, but they can reduce their risk of getting a second breast cancer. In the case of women without a genetic mutation, removing the opposite breast does not generally significantly reduce the risk of getting a second cancer, with some exceptions. So there are some breast cancers, such as lobular breast cancers, that tend to show up in the other breast a little more often than ductal cancers. The risk to women in the general population to get their first breast cancer is about 12%. And after they've had one breast cancer diagnosed, their opposite breast has a slightly higher risk of getting breast cancer. So it usually goes from 12% to about 15% risk in their opposite breast. If that woman is taking a hormone blocking therapy like tamoxifen, like Arimidex, one of the aromatase inhibitors, they do reduce their risk of developing that cancer in the other breast by about half. So it never goes to zero, but it's reduced by taking that hormone blocker. So there are a lot of reasons to do a double mastectomy, but the risk of recurrence is really only to the originally affected breast. Breast cancer almost never spreads to the opposite breast. So what you're doing by removing the opposite breast is you're reducing the likelihood of a second unrelated breast cancer.
So you mentioned earlier that there might be a lot of lymph nodes involved. So how many is that? Like when you say a lot of lymph nodes, is that 10? Is that 3? Is that 20?
With every lymph node that's involved by cancer, the risk of a recurrence in the chest area will go up a little bit.
Okay.
So our broad categories of risk usually group those categories into 1 to 3 positive lymph nodes,
Okay.
4 to 9 positive lymph nodes,
Okay.
and then something above 9,
I
10
see.
or more.
Okay.
Generally speaking, the more positive lymph nodes a woman has, the higher her risk of both a local recurrence in the chest area and also a distant recurrence somewhere else in the body. So that's why we'll usually add radiation therapy to the chest and lymph node area, even if a woman has had a mastectomy, to lower that risk of recurrence.
And when you determine the therapy plan, like in my case, they weren't able to measure the tumor because it was so large. But yet my oncologist had great disappointment about that because she felt like that was a component that she needed in order to determine how many chemotherapy, if radiation is necessary. So could you comment on that? Or is
It's
that
so hard to comment on something I
Okay.
can't see
Okay.
and understand.
Okay.
But you're right. I mean, oncologists make decisions based off of pathology reports.
Okay.
And we really rely upon our pathologists to give us as much information as they can. And so not being able to know the size of the tumor can be difficult. A lot of times cancers don't grow in one solid lump. They
Correct.
tend to be spotty,
Right.
and they skip around, or they grow in linear strands, more spider webby, again, rather than that solid mass. And so that's something we have to take into account when we get a pathology report that measures size, is where we're often calling each other, calling our pathologists and our radiologists, where I call Dr. Boatsman regularly and say, okay, you said the cancer spans 5 centimeters, but did you mean one big 5 centimeter, or did you mean 5 1 centimeter? Lots of conversations happen between doctors to try to understand it as best we can.
When you talked about the possibility of recurrence elsewhere in the body, typically is that something that happens fairly soon or years down the road? I know it's different for everybody, but what are, statistically, is that something that typically happens in the very near future or later?
So when do recurrences
happen.
Yeah. You know, when you're speaking and thinking words that are normal words just don't sound right to your ear. It depends on the cancer. So we look a lot at the biology of the tumor, and we look at the receptors on breast cancers, especially the estrogen and progesterone receptors and the HER2 receptor. And so we know that when breast cancers don't have any of those receptors, and we call that a triple negative breast cancer, that's a more aggressive breast cancer that tends to come back sooner, with the highest time for recurrence between year 2 and 3 from diagnosis. And then beyond year 3, the risk of recurrence starts to go down, and after year 5, it's very, very low. So even though that's the most aggressive kind of breast cancer, beyond the 5th year, that's the best kind of breast cancer to have after year 5. For slower growing, less aggressive cancers that are estrogen receptor positive, progesterone receptor positive, HER2 negative, those tend to come back later. So year 4 to 5. And then the recurrence rate begins to go down, but it doesn't go down very fast. And so between year 5 and 10, there's still a risk of recurrence that's measurable. You know, and boy, the number can be anywhere from 3 to 20% in that time frame, depending upon the stage of the tumor and so many other factors. And even beyond 10 years, as probably most people in this room have seen and heard about, some women will come back with cancer in year 15, year 20, even later, but those are almost always those very slow growing breast cancers where probably those cancer cells were always there, but they were so slow growing that they were lying dormant for many years until they finally showed up, you know, many years down the line. So that's why there's such a variation in recurrence time.
We have an online question for Renee. Does insurance cover the cost of breast forms if you've had delayed reconstruction and are waiting for surgery?
Yes. As long as you have a prescription from your doctor that states the prosthesis you need. Again, you know, with silicone forms, you have to be careful with what you have tissue-wise. So 6 to 8 weeks after a procedure, you would not want to put a silicone form. You would want to use something that's a little bit lighter, but yes, most insurances do cover them. Sometimes we do need to get medical necessity, and that's typically not a problem because our physicians are great. But definitely, I would ask your doctor to do that.
Dr. Pisano, is PRMA doing the lymph nodes transplants after you've had everything done yet?
Yes. I saw a patient in my clinic today who is a candidate for that. Who'll have a delayed tissue-based reconstruction. It'll be the tissue from the lower abdomen, and oftentimes we'll take some lymph nodes that are in the groin area, and we'll carry those with the flap, and we'll put those lymph nodes in the underarm area, the axillary area. And that's been shown to be effective in reducing. It may not eliminate lymphedema completely, but it can definitely reduce it and make patients more comfortable and get rid of the dull achiness and reduce some of the swelling. Alternatively, lymph nodes can be transplanted all on their own without a flap. So you can take a similar set of lymph nodes. It's a different set of lymph nodes than would come with the flap, the deep flap, the lower abdominal wall flap. And then those lymph nodes are transplanted as a cluster. They have their own blood supply. And we would transplant lymph nodes in that circumstance either to the underarm area or to another part of the upper extremity. For example, in the crease in front of the elbow or even in the wrist, because putting them in any of those 3 places can be beneficial.
So when you transplant them, will the problem be transplanted from where you took them from?
That's a very good question. Oh, the questions are amazing today.
So you're taking care of one problem by putting
Yes.
them in the arm, but if you're taking them from the groin area.
So when we transplant lymph nodes with a deep flap, as long as we just take a very small cluster of lymph nodes, we would very rarely create lymphedema in the lower extremity. I haven't seen that happen. However, you can have some problems with lymphatic drainage in the area where you retrieve the lymph nodes, and so that might require a lower abdominal drain for a more extended period of time than would usually be the case after a flap. Now then, if you take the lymph nodes as a separate cluster, it's a different group of lymph nodes, you have to be very careful because there's a certain anatomic line you cannot cross or you will interrupt the main outflow of lymphatic fluid from the lower extremity. So that requires a little more care and would require the help of, say, Dr. Boatsman. We would have to get help from our radiology colleagues to identify the proper channel of lymph nodes actually to avoid and capture the ones that we want. So it's a great question, but we now do that, and it's fairly routine. So
Dr. Pisano, is that done? Because I already had a deep flap done. So you're saying that that's done with the deep flap. Can it be done after the?
yes, as I
Okay.
mentioned, you can transfer that separate cluster of rows. I probably wouldn't put them in the underarm. I'd probably put a little 3 or 4 of them right in the front of the elbow. Yeah.
Does insurance cover that now?
Many of the big carriers consider this experimental, but as you all know, things in medicine can work, and none of us on the panel would consider them experimental, but insurance carriers are not always our friend. But so, you know, it's tough, and sometimes we can't get it covered by some of the carriers. Sometimes we can, but we try.
What are some of the things, you know, in your role that you can do for after breast cancer surgery and reconstruction for women who have lymphedema that maybe aren't candidates for or haven't had the lymph node transfer to help with some of those symptoms?
Okay. Yeah. So really the standard of care still is what we call the complete decongestive therapy. The longer a person waits before they get in to see a certified lymphedema therapist, and the more involved the lymphedema is, the more involved the treatment is. If we can get somebody in the very early stages, or even before they even perhaps see the clinical manifestations of lymphedema, the treatment is actually fairly simple. We would start with education. Talking about risk reduction practices is a big one. So avoiding trauma to the arm in the form of cuts and scrapes and bruises and burns and all of those things. So we talk at length about how you can just adjust your life in order to reduce that risk of getting injury. We talk about just good lifestyle habits. Exercise is really important, and the thinking used to be that exercise was a trigger for lymphedema, but now it's been shown that that's actually not the case, that exercise is very good for lymphedema and actually can reduce your risk as well as reduce the severity in people who already have lymphedema. So we do a lot of exercise training, and we talk about that and how you can adapt your lifestyle to be more proactive in that regard. Thirdly, we talk extensively about nutrition, which is a really big thing right now for lymphedema, because there has been shown, there's evidence out there, and we've known this for a long time, that once lymphedema starts, there's an entire inflammatory process that occurs and basically causes a snowball effect. So the stagnant fluid in the tissue leads to inflammation. The inflammation leads to stasis of the lymph vessels. And the valves don't work as well, so the transport system is not as good. That leads to more fluid, more local inflammation. So we really try to talk about ways that you can reduce inflammation in your daily diet, which is also good for reducing your risk of cancer as well, and just about everything else that's chronic. So we talk a lot about anti-inflammatory diet. And I do want to mention, there is a book, and I'm going to plug it, recently came out, and it's a book, it just came out recently. It's called Lymphedema and Lipedema Nutrition Guide. This can be found on Amazon. I have it in the clinic as well, but it talks a lot, kind of technical, about the role of nutrition and how it interacts with the lymphatic system, so it's fairly technical, but then it also goes into some common, practical things you can do and working to change your diet. It has great recipes and a lot of support. So in addition to risk reduction practices, this is a big part of our education. Finally, if a person needs to go through the full course of complete decongestive therapy, typically we would bring them in daily for anywhere from 1 to 3 weeks, typically, and perform a treatment called manual lymphatic drainage, which is like a massage. And what we're doing is really trying to stimulate the local lymphatics and reroute the stagnant fluid into other areas where lymphatics and the lymph vessels can process that fluid more readily. After that procedure, we apply multi-layered compression bandages, and these bandages are pretty bulky. It consists of foam underneath and several layers of bandages, and some of my patients are laughing because they've been through this before and it's really not fun. But it's really important because it really helps stimulate the lymphatic system and then keep the fluid from accumulating, keep more fluid from accumulating. This has to actually be done typically daily because there's a reduction in that volume and we have to keep readjusting those bandages in order to keep that volume going down. Once we get the volume down as much as we believe is the best result that we can get, then we fit you into a compression sleeve. And the compression sleeve is thin. It doesn't restrict your movement in any way. Typically, they're very comfortable. A lot of people find that they help reduce discomfort, and so they can be a very nice thing to do. They come in anything from beige and brown and black to, if you ever wanted to have a tattoo but didn't have the nerve to do it, you can get sleeves now that look like tattoos, lace, whatever. They come in all sorts of fun designs. And then finally, when we get through treatment, we at Forte, at my clinic, do regular follow-up care. So we would bring you in after a week of treatment and then regular follow-ups to make sure that your home program is doing okay. In addition, finally, to managing the lymphedema, typically we see all sorts of other physical issues that accompany that. Rarely does lymphedema stand alone. There's almost always some sort of other arm problem that's going on. Rotator cuff syndromes, tendinopathies, bursitis, arthritis. We talked about cording. So all of these things need to be managed as well because we want a really good, healthy state of the soft tissue in order to keep that inflammation down and to help you manage it better long term.
Okay, and then a general question for anyone on the panel. At what age do you recommend a man with a strong family history of breast cancer to request screening?
So I guess that, it depends on the history. And really what you would want to be aware of is the types of cancer that the family members have been diagnosed with and the ages at which they were diagnosed. And then to see if that the patient would meet criteria for genetic testing, because that would be the best way to do it. The other options are to start with self-exam, just like we recommend for any woman, and then to start with a clinical exam of the breast tissue area in a male somewhere around the age of 40. Again, depending on the types of cancers and the ages at which the family members were diagnosed.
And less than 1% of population are males that get breast cancer. So, but it does happen. I've had 3 in the past 4 years since I've been working at Methodist. So it does happen.
Okay. Another question from online. Does reconstruction for a delayed reconstruction for a patient who's had a double mastectomy already allow the breast to look normal after surgery, or will they always have some sort of deformity?
I think in this day and age, at a practice that does a lot of breast reconstruction, you can get a very, very good result. I really do. I think factors that contribute to the very best results we can get are, did the person have radiation therapy? Because that on the one side will be a limiting factor in terms of the elasticity of the skin and the ability for that skin to drape over whatever you put under it, be it an implant or tissue. How thick the native breast and chest skin is after the mastectomy, what the person's overall body habitus is, what method of reconstruction reconstruction they choose, but I would say you can get very, very good results. I think we're in a really good place in the world of breast reconstruction for what's possible. So I'm an optimist in that regard. I think we can get great results.
And sometimes normal, it may not be exactly what they used to look like, but many times they're better than they used to look like. I mean, maybe not normal is maybe not the right word, but better.
Yeah.
That's okay with me.
How often can you get it fixed though? Because when you have radiation, like you said, it hardens the breast after it's been reconstructed and lifts it up and leaves you not looking like you were right after reconstruction. How often can you have it done in order to get it right?
Radiation usually doesn't get in the way of our ability to do a reconstruction. And in our practice, many of our patients have had radiation therapy. You're touching on an important point, though. Obtaining symmetry in the setting of a person who's had radiation and, for example, had a preventative mastectomy on the opposite side is a challenge. I'm not gonna lie, that's a challenging circumstance. But again, I think you can get very good results. I think the method of reconstruction in this particular circumstance, in the setting of radiation, does matter. And I think tissue reconstruction definitely helps the outcome in the setting of radiation because you're putting well-vascularized tissue under the radiated skin, tissue that has its own circulation, separate from the skin, that is bringing that circulation into the skin, and I think that can be of great benefit. Now, you have a guy, that's me, and here's our table. I'm putting it on the table. In that circumstance, I favor tissue reconstruction for the reason that I mentioned, that you're bringing newly vascularized tissue into the area that can be of benefit to that overlying radiated skin, as opposed to an implant which doesn't do that. An implant has no circulation of its own, so you're not getting that benefit.
Okay, but are we on the same page? I'm talking about after you've had the reconstruction, you had a recurrence. You have a...
And then you had radiation.
Yeah, because of the recurrence, not because of the first time around, but the second time around.
Okay, that's a separate issue. Radiation after reconstruction. I'll begin where I left off with a tissue reconstruction. Can a tissue reconstruction withstand radiation? Yes. We would try to work carefully with our radiation oncologist to manage how that radiation is going to be delivered to minimize the radiation to the flap itself as best we can. And sometimes that's possible and sometimes it's not. If it's a tumor on the chest wall and the radiation oncologist has got to basically go through the flap to get the beams delivered where they need to go, then that's a tough circumstance. If the recurrence is more superficial, maybe there's a way to direct the radiation to avoid the majority of the flap if it's a flap reconstruction. In the circumstance of an implant reconstruction, that's tough because that's a person who's almost guaranteed to get what we call a contracture. So radiation over an implant doesn't go well in terms of preserving softness of the tissue and preventing a contracture. Did that help?
Sort of, kind of.
Can we briefly discuss the differences of a mammogram versus an MRI in diagnosing breast cancer?
Well, first, I'll get off topic a little bit and just say that, we're here today and we're talking and we're exchanging information, we're helping people learn more. And throughout this whole process, people may start at different points on what they know, but ask as many questions as you can through your process. There's always people here. we always hear new questions, but most of the time somebody's already asked that question before, so give yourself as much information as you can so that you can make the best information or the best decision for yourself throughout that journey. So I just wanted to get off topic a little bit. Now back on topic as far as screening goes. So if you take the population in general, their overall best test is going to catch a lot of cancers, be cost effective. You can do it on a big city like San Antonio. Is going to be the mammogram. Up until several years ago, we just had the traditional mammogram. A few years ago, the 3D mammogram, which is sort of kind of a souped-up mammogram, came to the forefront and is largely replacing that. Actually, Governor Abbott signed a bill which is going to require carriers to cover it, like they did a normal screening mammogram. So a screening mammogram was your best bang for your buck test. The 3D mammogram is going to take you that next little bit step, one in cancer detection, but also in the need for additional imaging for things that aren't cancer, just sort of plague the whole process along the way, making people anxious and needing extra tests to prove they don't have cancer. The next step above that would be a breast ultrasound, which doesn't use radiation. It's done with echoes. It's not as good as a standalone test, but for women, particularly if they have some risk in family history, if they have a large percent of their breast is replaced by the glandular tissue, which can obscure masses, that's the next step. And finally, the ultimate test is breast MRI. That's probably our most accurate test. That being said, there's a lot more involved to that. Screening mammogram is pretty quick in and out. You can get it in a lot of places. Certainly there's some discomfort that goes along with it, and that can vary from person to person. But an MRI, it's a much longer test, it's a much more expensive test, and involves getting an IV dye. And so traditionally that's been reserved a lot more for women who have had more risk. They've had a lot more family history, and that can get a little bit more gray, because if you're a woman and you know you have a family history, what's significant for you? Well, maybe your aunt had breast cancer. Well, maybe two aunts did. Well, maybe it was your mom. And that kind of is a more formal educational process to figure out what that really means to you, and what the best test is for you. But a mammogram is the #1 best starting test, kind of all comers. And an MRI doesn't replace that. It would still be an adjunctive to that, because if you are at enough risk that we're starting to talk about MRI and have that discussion, say we're going to do everything we can to detect every cancer as early as we can, as small as we can. We don't want to miss any. And so complementing those two tests is the way to go. But basically, as your risk or need goes up, you kind of go through that process for progression from the mammogram, now largely, which will be done with 3D. If you need a little bit more based on risk or other factors, then an ultrasound. And then if you know enough about your history and you do meet criteria, then an MRI as an adjunct to that is sort of the recommended. And as much as the guidelines now kind of disagree sometimes about what the right screening test is, once you get to that risk, the level you do have risk, they all sort of agree that if you hit that level, then you should start having MRIs, or start having the discussion if that's the right test for you. And again, we're all about providing information. So we say, well, this is the guidelines say, you meet this criteria, it's available to you, and then so it's there for you if you want to take advantage of it.
Stacy, the nurse navigator role, is that something that just walks with the patient through diagnosis and treatment, or do you walk with patients all the way through surgery and reconstruction if they choose to go that route?
It's through the entire continuum of care. So hopefully we reach out to them when they're first diagnosed, and that's typically when they go see their general surgeons. They get recommendations. Oftentimes they'll go to surgery, or they may need to go to a medical oncologist. So we follow them through that whole pathway. They go through radiation all the way up until what's called survivorship. If they start taking hormone therapy, we follow them for a couple months to ensure that there aren't any questions, concerns, or side effects, and they're following up with the physicians and the recommendations that the physician
Dr. DeBerry, I think this would be a good question for you. In the setting of immediate reconstruction, which is where reconstruction happens at the same time as the mastectomy or lumpectomy, do you work first and then exit the room soon after? Are you working at the same time as the plastic surgeon? How does the timing of that work?
Yeah, that's a really good question. So when we're working together, what'll happen is we often try to work at the same time, and Dr. Pisano and his team will start preparing the tissue on the lower abdomen while I'm doing the mastectomies. And if we're doing one side, then I do the one side and do what I need to do, and then I do leave. And then his team finishes and does the remainder of the surgery. But we try to do that so that we're efficient and decrease the amount of time in the operating room as much as possible for patients.
And then, Dr. Pisano, could you briefly touch on immediate reconstruction, and especially in the setting of like a lumpectomy with oncoplastic surgery?
Sure. So a fairly new development in the world of breast reconstruction is what's called oncoplastic surgery. And this is a technique in which a person having a lumpectomy or partial mastectomy would then undergo a procedure from a plastic surgeon to get the best breast shape possible with the remaining breast tissue that's left. Oncoplastic techniques work best when the tumor is located in an area that would ordinarily be removed in the setting of a breast reduction or in the setting of a breast lift, what we call a mastopexy, because sometimes when we do a mastopexy, we do a little bit of a reduction, not a formal reduction. So tumors that are located within the kind of the standard patterns that we would use for a breast reduction or a breast lift. If a tumor is located kind of in a border zone, in an area where we wouldn't typically remove tissue with some of the standard breast reduction techniques or lifting techniques, then in my view, an oncoplastic technique loses its power. It's not as easy to execute and not as beneficial. And I'll take it one step further. If the tumor is located in an area where a major blood supply is coming into the breast that is going to be compromised by that tumor removal, even though you're leaving other breast tissue, further manipulation of the breast may not be favorable, and you can end up with what's called fat necrosis or injury to the native breast tissue that's left. So oncoplastic surgery in general has been a game changer in our specialty because it's become an important tool for women who want to have breast conservation, but we can make the outcome more favorable. I will tell you that the use of oncoplastic techniques varies geographically in our country. So when I go to our annual meetings or meetings devoted to breast reconstruction, there are parts of the country where oncoplastic techniques are used more widely, and that's a very complex thing that has to do with the demographics of a given community, a given city. Do in general women get diagnosed earlier? Do they get diagnosed later? And lumpectomy is not an option. So that's a very complicated question and a matter of discussion and debate at our meetings. But I don't know if I answered the second part of that question. But
I have a question.
Yes.
Can that procedure be done post-mastectomy, like a delayed mastectomy?
An oncoplastic technique, yes, can be used after the lumpectomy is done.
No, what I meant was, can it be done once you had like a double mastectomy later?
After a traditional mastectomy, then we're talking about a full reconstruction. So oncoplastic means a partial mastectomy, or what we think of as a lumpectomy, breast conservation surgery. Yeah.
Hi, this is my first time here. I came here first before going like to my primary doctor or through my insurance, whatever. I'm already I know this is something I always say, I've been healed by God, but I'm a 15-year lymphectomy breast cancer survivor already. And I am so tired of using the prosthesis and everything. I hate it already. And I said, why have I never gone to check? And so I've seen y'all on Facebook and all, and I said, I'm gonna go here and try to find out what I can. Should I go to my doctor first? Can I see y'all? And then y'all tell me what procedures after that. I have my insurance. And one time I happened to call my insurance company just to say, what would it cost to have a breast reconstruction? And she looked it up and all that, and it's only $325 or something like that. my price. And I'm like, what? Are you sure? And I didn't go any further. I just like, okay, maybe I'll ask someone else. And that I will mention is Aetna Medicare, that's my provider. So I would like to have one done, on it's my lumpectomy breast and the rest, And I don't know and I had the whole thing. I had chemotherapy and I had radiation. So would that be something that I would be able to get?
Yeah, in the circumstance here, as Dr. Liang said earlier, I'd have to examine you formally and see it. But typically, somebody in your circumstance on the non-cancer side might need a lift and somewhat of a reduction, and on the side that had cancer, maybe a lift and some, again, manipulation of the tissue. But that's a common circumstance. And some women come many years later.
Mm-hmm. And should I go? I mean, I have to go through my doctor first before I
Yeah, come see us.
We have a question online about genetic testing and children's risk of developing cancer. If someone has tested negative for the breast cancer gene, but has had breast cancer, should they worry about their kids getting cancer, and should their kids get genetic testing?
Well, a child cannot inherit the gene that a parent does not have. So if the parent who's had cancer for which there's concern has had the proper complete genetic testing that is indicated, and that testing is negative, then the child does not need genetic testing. In the case of a woman with breast cancer, many women have had the BRCA genetic testing years ago, but have not had updated testing. There are now larger panels that include many genes that go beyond BRCA that can cause breast cancer, and so in many cases we're retesting women to update their original testing to see if they might carry one of the newer, more recently discovered genes. If that woman tests negative for the panel, what that tells us is, to the best of our knowledge, she does not have genetic breast cancer unless she has a gene that hasn't been discovered yet. And there are probably genes that haven't been discovered yet. So sometimes there are family histories that are incredibly strong, super compelling. You know there's a gene there and all the testing is negative, and you gotta believe there's a gene there that just hasn't been discovered yet. But in other cases, there is familial breast cancer, but not genetic breast cancer. And what that means is the genetic testing really is negative, but there's still something going on in the family causing many of the women to get breast cancer. Usually, these are women who are older. So for example, in the first scenario where I said there's gotta be a gene, this is when, every woman in the family practically has had breast cancer, lots of ovarian cancer. They're all young, meaning 30s, early 40s. That's probably a genetic breast cancer. But when a woman's mother had breast cancer at 75, and that mother's sister, so a maternal aunt, had breast cancer at 60, 70, or 80, and then maybe a great-great-grandmother, we think she probably had breast cancer. That's probably not genetic breast cancer, but it may be familial breast cancer, which means there's something either environmental going on, or there are factors in someone's genome, the things that they inherit that aren't necessarily the genes themselves, but things in our body that control what our genes do indirectly. And so we don't really understand a lot about that. We do know that sometimes there are environmental factors that, for example, many women in a family are obese, and we know that obesity is a risk factor for breast cancer. So that's an example of an environmental factor that's also familial because the obesity runs in the family. So those are some examples of things that can cause breast cancer in a child that might not be related to the BRCA gene, for example.
Okay. Are there options for women who have had a lumpectomy and have asymmetry and don't want reconstruction? So I guess this would be a good first.
Absolutely. We have what are called partial forms. You could have a contact silicone partial form. You could use a foam partial form. So, just like, with the reconstructions, we have to look and visualize and measure and apply the items into either special bras, or, we do have, especially the younger women who want to wear, the camis and what have you, we can truly have no issue putting a partial on, and it works really well, and they stay in place. So definitely, and with the reconstructions, what I like to say is, we always tell a patient, honestly, whatever you come in with, we more than likely have seen before. So basically, it's like molding clay, before and after, If you come to me and see me and you want, it's just for temporary, that's fine. I'm gonna help you the best way that I can. But definitely a partial form will work.
Okay. And then can we briefly touch on regaining sensation after a mastectomy through some of the sensory nerve reconstruction techniques?
Yes, this is a hot topic in the world of reconstructive surgery and the primary surgical oncology side of things. To begin with, a mastectomy in some form or fashion is going to interrupt sensation to the native skin overlying the breast. What determines how much sensation is left is the person's own anatomy, number one, and number two, how thick the native covering of skin and soft tissue over the actual breast tissue can be left. Number three, whether or not the nipple and areola is preserved. And now, in this day and age, it's very common for us to be able to preserve the nipple and the areola with the native breast skin. The sensation will not be normal, but it will be better than if it's removed and you have just the remaining native breast skin closed over an implant or over a flap, or the presenting area where the nipple and the areola was is the skin from, say, a flap, say from the tummy. In that regard, I'll tell you, Dr. DeBerry and I have almost routinely now, I would say, we might have had a few exceptions, do nipple areola sparing mastectomies. It's on my mind because I saw one of our patients today in my clinic. And she does have very good breast sensation and very nice appearance. And furthermore, Dr. DeBerry did the work. She did the mastectomy through an inframammary fold incision. And so, viewing the patient straight on, you can't even see that she's had anything done. taking this one step further, when we do our flap reconstructions, we try, where possible, to hook up a sensory nerve that would come with that transplanted tissue. So in the case of the DIEP flap, which comes from the lower abdomen, we try to find an adequate sensory nerve, and we hook that nerve up to a sensory nerve in the inner chest or outer chest so that the flap can regain some sensation. Again, it's not normal sensation, but it's the kind of sensation that makes the tissue feel like a part of you. It's pressure, hot and cold, and those are things that make the reconstruction feel like a part of you and not something that's stuck on. Sensory nerves are very variable when we find them with the flap, wherever it is, the outer thigh, inner thigh, the abdomen. Sometimes they're very small and they're less than a millimeter in diameter. They're so tiny and fragile, they're just not very good to hook up and they don't do much. Other times we can find a very stout, larger sensory nerve, and we know when we hook that up, we're gonna get something. So there's some variation there, but where possible, we try to reestablish some sensation.
I'm also new here. My question has to do, I had a double mastectomy, and when they did it, then I had the expanders, and right now I have a, because the other one, it got exposed.
Yes.
So they had to take it out.
Yes.
Okay, the question is, I have a lot of pressure on my chest.
Right.
A lot. I have to sleep sitting down. Well, I'm gonna be having a D flap in December with Dr. Christopoulos. Is that gonna help me any? Because it's very uncomfortable.
Yeah, I think it will help. I think for patients who have pressure and tightness around an expander or an implant, having that taken out and a tissue reconstruction can be very helpful. One of the reasons why patients have tightness is that typically the expander, the temporary implant, and then the final implant is put under the pectoralis major muscle. And the reason that's done is to give more soft tissue coverage over the top of the implant. The thing is, though, the pectoralis major muscle was not designed to have anything under it. The pec muscle is to my way of thinking, a core muscle in the body. Everybody in the room would know a core muscle in the abdomen. We all think that way. But in my view, core muscles are muscles in the central part of the body. So muscles in the front of the thigh, the abdomen, and the chest. So the pec muscle, in my way of thinking, is a core muscle. It's tightly plastered to the chest wall. It's a powerful muscle. It just wasn't made to have anything underneath it. So some women have a lot of difficulty with that. So by taking the implant out from under the muscle, putting the muscle back down on the chest wall, and putting the flap on top of it, will go a long way towards relieving discomfort. It may not relieve it entirely, because the mastectomy itself can produce discomfort that can be kind of long-lasting. But generally speaking, yes, I think it can be very helpful.
Okay, another question. Like, I have the implant here. My scar here is very neat. Now, this one here, I don't have the implant no more, but I don't have a scar. I have like if you had bunched up a piece of material, bunched up, and then sorted up.
Dr. Sapolo will make that look better. I know. He's really good.
No, it is horrible.
No, he'll fix that. I promise you. He'll cut that scar out, and that scar will be replaced by skin that comes from the tummy with the DIEP flap, and that'll be all, fresh tissue there, fresh skin. He'll remove that scar. Any of that tethered, dense scarring, he would typically remove. Yeah, he'll make it better.
Dr. DeBerry, I'm the breast cancer nurse navigator at Metropolitan Methodist Hospital. I have quite a few patients who say, I'm not going to want reconstruction. I'm sure I'm not going to determine your approach, your surgical approach for a mastectomy?
So I try to do it case by case and after discussion, with every patient. There are a lot of women, and I feel this very strongly, when women are making their decision about how to have their cancer treated, they're making that decision under extreme duress because they're dealing with cancer, and that's a very scary thing. And so I would tell you that I try to get the best feel that I can for the patient and what their long-term needs and goals are going to be. And if they tell me that they really absolutely are never going to want reconstruction, then I do an old-fashioned mastectomy and I remove the skin and I close them in such a way that they're flat across their chest so that they can best be fitted for a bra with a prosthesis. There are many women that tell me that they're unsure, they don't know what they're going to want to do. There are many women that actually will require radiation treatment, and so their reconstruction will need to be delayed. And in those women, I will do a skin-sparing mastectomy, where I just remove the nipple-areolar complex and leave the remainder of the breast skin intact. And I close them, and I tell them it's going to look terrible when I do this. It's going to look very bunched up, and but that skin hopefully will be healthy and will be able to be used at the time when they decide to have the reconstruction done. So again, it's very difficult to decide that at the time. If they tell me that they don't want reconstruction and they're never going to want it, then I do remove the majority of the skin and try to leave them as flat as possible. If we feel like there is some inkling, some chance that they are going to want reconstruction, then I do leave the skin behind. And what I tell ladies is that if you decide after a year, after 2 years of having the skin there, but you decide, I really don't want to have the reconstruction, we can always go back and revise that mastectomy site and take that extra skin off, okay? That means more surgery, but it's an option that's available if we decide that.
Any more questions? Okay.
We've been hearing about some new techniques with the radiation with implants. One recently, there was a gal that's getting, she had a mastectomy done, and they put the expander in, overinflated it on purpose to stretch the skin, and then reduced it for her to, or deflated it to have her radiation. Is that a new trend or a new way we're looking at things now, or is that an unusual circumstance?
That is a very good question, and here again, this is a very, in some ways, controversial topic, and it's a hot button kind of topic at our meetings. As Dr. DeBerry said just a second ago, typically if a patient is going to get radiation, we would postpone reconstruction of any kind. As a way to try to bridge the gap between mastectomy and radiation and reconstruction, there is a technique which you referred to where an expander is put in, the temporary implant, and it's inflated, and either left inflated during the radiation process or inflated but then just prior to radiation deflated temporarily so the radiation can be delivered and then reinflated again. And that technique kind of took its origin at MD Anderson in Houston. It can work, and it has the benefit of keeping the skin envelope, how I would say, out to length. It keeps it more pliable and retains the surface area so you can put something under it later. Again, either an implant or a flap. In my world, again, after radiation, it would be a flap. But so it can be beneficial. It does carry with it, though, a high complication rate. Because if you think about it, you have a mastectomy defect, You're putting the expander in, as you said, you're kind of inflating it, maybe even overinflating it to counteract the contraction of the skin that's going to happen with the radiation. And then you're deflating it and then reinflating it after each radiation treatment. It's very labor intensive. It requires the personnel, either on the plastic surgery side or the radiation oncology side, to inflate and deflate the device. And it requires the patient to kind of be able to withstand that. It is tough. So, in summary, it can be helpful, but it can be fraught with problems. And I would say it either goes really well or it doesn't. I don't think there's a lot of in between. Just because you're asking the tissue and the device and the team taking care of you, there's a lot of moving parts there. A lot has to go right for it to work.
One other question with the reconstruction. Cost-wise, this is a question that comes up quite often with women who are planning extensive reconstruction, looking maybe at 3 different procedures with the flap, and just plain can't afford the out-of-pocket. Even though they have insurance, they'll tell me, I can't afford the out-of-pocket. Can something less expensive be considered at that point, or what are your thoughts when you have the woman saying, I just can't handle this, but I want reconstruction?
Again, that's a very good question, and that's part of the reality of the day-to-day workings of our care. And as Stacy Schuler said, that's barriers to care. Cost, absolutely. It's a spectrum. So in the best of circumstances, let's say we have a patient that can undergo a nipple-sparing mastectomy, because that's going to lead to the fastest point of completion, because it will require the fewest steps. So if Dr. Liang or Dr. DeBerry send a patient to me and I talk to them and say, they know what I'm going to ask. The first thing I'm going to ask Dr. DeBerry is, can we do nipple sparing? So if the answer is yes, then you're almost in a circumstance where you could do a 1-stage reconstruction of something, maybe an implant, or maybe a flap reconstruction where, yeah, in the best of all possible worlds, I'd like to do a revision, but you know what, they look pretty good without it. So that's the best of circumstances. On the other end of the spectrum is a delayed reconstruction with radiation. Yeah, in the best of all possible worlds, we need multiple steps there. So then I tell patients, if they're coming to see me with the concern you're raising, can we do something? Can we do step 1? And then maybe step 2 is a year from now or 2 years from now. There's no hurt. We'll cross that bridge when we get to it. But, it merits a discussion, and we'll try to get the patient to the best possible result with the fewest steps, working with our colleagues to come to the best possible outcome. And then it's truly a team thing. Dr. DeBerry may say, hey, I can't do a nipple sparing. The tumor's right under the nipple. Can't happen. Not happening. Then that's a different discussion with the patient, and we try to get them to a point of completion as best we can.
I'm going to just chime in on that too. There are just some incredible organizations that patients with insurance even can reach out to that help cover the cost of deductibles and out-of-pockets. Thrive is one. Remember Betty is one that we're actually fundraising for right now. We have a huge list. There's a resource on our website for it, but there are so many cool organizations that help, even with people who have insurance that can't afford deductibles, out-of-pockets, that sort of thing. So those are good resources to reach out to as well. Yeah. All right. Anything else?
I have one more question.
Sure. Go ahead.
When you talked earlier about we're talking on that controversial topic about screening or recurrence, and I think it was you, Dr. Pisano, who mentioned that usually you feel a bump or something. And I understand that the risk of a lot of the screening makes it more desirable not to have it done, right? I mean, is it an option?
I'm going to defer to Dr. Boatsman here, but that's a very valid concern. This is an opportunity. I'm going to kind of take a page out of Dr. Boatsman's book and take this opportunity. You know, the people on this panel are the best in the business. So when you're talking about screening for a recurrence after a reconstruction, this is my opinion, you can't have any radiologist doing that. You have to have Justin Boatsman, or you have to have one of his colleagues. Because there are going to be some radiologists in the community, not our community, somewhere else, they're not going to know what to make of a flap and the overlying tissue and what that is. I promise you. Again, when I go to my conferences, I see in real time this unfold in our discussions, or when I'm on a panel and these kind of topics come up. So you need a pro. You need Justin to engineer what's going to happen to you or the given patient, or you need Dr. DeBerry or Dr. Liang to weigh in on this topic. So I didn't mean to make it sound so simple. Again, the short answer might be no, but for the person who's overly anxious or has certain other factors of risk, the location of the tumor, extent of the tumor, the grade of the tumor, things of that nature, then yes, we need a discussion with our multi-specialty colleagues to come to the proper solution. And in this community, we will. Because if you have that issue, I'll send you to one of these colleagues and we'll figure it out.
Just to add a little bit to that, I think that, you know, one of the most important things is trust in your doctors and having the ability for your doctor to give you some reassurance in those areas. Because again, it is controversial. And so yes, we could send you for an ultrasound, but unless you have someone who is knowledgeable about, like Dr. Pisano said, the reconstruction and what it looks like and what to expect, you're gonna get an abnormal result. And then you're gonna increase your anxiety even more. And then you're gonna go down the road of making those women go through unnecessary biopsies.
Okay,
And
I did realize that with those other tests, you do get a lot of false positives, but I didn't realize that was also common with the ultrasound.
Yes, it is. It is. In the hands of someone who's not familiar with what reconstruction looks like, you will get false positive results. And so that's why we just say we take it always with caution, you know. And so if you come, if you're with one of us and we're familiar with the situation, then it's good, and it can be very useful to have imaging and to have those kinds of tests done. But if you're somewhere else where they're not familiar with looking at that, you're going to get, in all likelihood, you're going to get more scared because there's going to be a positive result, and then we're going to end up having to sort of chase our tails and get back to everything is actually okay.
Yeah. Just to add a little bit, you know, we'd said earlier, after mastectomy, the risk of a local recurrence is 1 to 2%. It's probably closer to 1%. So if you think about all of the breasts you're going to screen with ultrasound to find a 1% recurrence, the majority of those 1% will be found by the patient herself. So because everything is pushed forward, the breast tissue that's left behind under the skin is being pushed forward by the implant or by the reconstruction. The vast majority of these 1% of recurrences are palpable and are found by the patient when they're very small. So it's less than 1% of patients for whom you will find a recurrence on a random screening ultrasound. So we're talking about really, really tiny numbers, with the trade-off being cost, false positives.
The anxiety.
Yeah, right.
Well, it is reassuring to hear you say that, like, you'll know, you'll feel it,
Yeah.
because if you've never felt it before, that's where it's scary. But
And this is just another example of being familiar with what your breasts look like. You know, do your monthly breast self-exams, stand in front of a mirror, understand what they look like, lie down, do your exams, and just do it routinely. And like Dr. Liang said, it's typically very superficial, so they can be found.
just one more.
Yeah,
Dr.
last question.
Dr. DeBerry, how often do you see women coming in with already in their mind saying, I'm going to want a contralateral prophylactic mastectomy? Is that very common?
It's very common, yes, it's very common. And so what I try to do is I try to just make them take a little bit of a step back and hear all the options. I want them to understand that, like Dr. Liang said earlier, removing the other breast does not impact survival. It does not impact long-term recurrences unless you're a genetic mutation carrier, and then of course it does. But for the vast majority of the population, removing that other breast does not necessarily impact survival, okay? And so we go through that very carefully. Then I take the sort of opposite approach to say, okay, there's survival, okay? We're gonna do this. We're gonna take care of this cancer. Now we have to make it such that down the road, you are happy and you are the best that you can be. And sometimes for some women, that is removing the other breast. And I think that you have to consider that whole picture in making that decision. So I go through very carefully the science behind recurrences, the science behind survival. And then I talk about the psychological and the emotional recovery long-term for patients. And I think that you have to consider both of them, because the data shows that lumpectomy is equal to mastectomy in treatment as far as survival and recurrence rates. And so we kind of put that aside. After we discuss that, we kind of put it aside. And then we talk about the next part of recovery, which is the psychological and the emotional recovery that women go through after having to go through this process.
And the cosmetic outcomes, because for many women, doing one breast will leave them rather very asymmetrical, right? So for many women, the other breast mastectomy reconstruction is much more about cosmetic results than it is about anything.
I would like to, here again, this is an important topic and something that would be discussed in no uncertain terms at our breast reconstruction meetings. In my lifetime of doing breast reconstruction, so 23 years now, there has been a sea change in this. So when I started my practice, unilateral single reconstruction was the rule. Now, bilateral reconstruction is the rule, but again, this is a geographic thing. In our practice, most of the women who present for reconstruction are getting a double reconstruction, a bilateral mastectomy and bilateral reconstruction. Why is that? Well, it has to do with the way we do our reconstructions. We do a lot of tissue reconstruction, and so the line of reasoning goes, as Dr. Liang said, symmetry, and then if we use the abdominal tissue, we have two halves to work with. If we use one half and we discard the other, then if a patient develops a cancer on the opposite side, that option's not available. We have other options, but this is the gold standard. That can weigh in the decision. The other thing that weighs in the decision is the way in our practice that we approach breast reconstruction. We are not dabbling in breast reconstruction in our practice. That's the core service. That's all I do, really. And so we can approach the patient with a high degree of confidence that our flap reconstruction or whatever reconstruction we pick, it could be an implant, is going to have a high degree of success. And that's where the rubber meets the road in the world of reconstruction. Because if you're in a practice where you do a couple of tissue transplant reconstructions a month, your way of thinking about the reconstruction is going to be colored by your experience. We do 4 to 6 individual breast reconstructions a day with tissue. So we're never not doing breast reconstruction in general, and certainly with tissue. So we approach it very differently because we're in the moment, we're doing it all the time. And so if a patient says, you know, I'm thinking about doing the other side, or if they haven't mentioned it, I might say, well, have you thought about doing something with the other side? And they as Dr. DeBerry said, you know, for my peace of mind, I don't want to have to go through cancer again. I know I might not live longer, but I don't want to entertain this problem again. Then I can say, you give me the work order, I'll do one side or I'll do both sides. And I don't have any heartburn about that. But when I'm with my plastic surgery colleagues from other places, they will approach it differently, especially from other countries. You get somebody from England where they have a National Health Service and socialized medicine. This discussion would almost be heresy because they don't have the resources, they don't have the wherewithal, they don't have, it just wouldn't be, it would be inconceivable. So.
All right, and I think we're out of time for this time, so thank you, panel, for taking time out of your evening and coming out and chatting with everyone. I know there's questions online that we didn't get to, so we will be sure to reach out to you guys and get answers to those who asked questions there. And thank you, ladies, for coming out tonight. We appreciate it.
Thank you, everybody.